Thank you, Dr. Alok, for inviting me to this wonderful instruction course. And is my screen visible? Am I audible?
Yeah, you're audible, very well audible.
So my talk today is about pterygium excision with conjunctival autograft, evolution in securing techniques. What are the goals of surgery when we are treating pterygium? We have two major goals: to achieve a good cosmetic outcome and minimize the chances of recurrence. Dr. Parehar has very nicely talked about all the evolution of surgical techniques. So I will not discuss in detail about these different surgical techniques. What I'm going to concentrate today is about the conjunctival autograft transplant. Now, this was first described by Kenyon et al. In 1985, which gives us a good cosmetic result. The recurrence rate, although low, is variable between different studies, and this variability is because of the definition of recurrence use as well as the expertise of the surgeon. The anesthesia for the surgery can either be peribulbar or subtenons, depending on the comfort of the surgeon. And again, the position of the surgeon may be superior or temporal. Instilling topical brimonidine 10 minutes before the procedure actually causes vasoconstriction and decreases intraoperative bleeding. So before we talk about the surgery, let's understand a little bit about the parts of pterygium and what we are aiming at in the surgical procedure. The head is the part of the pterygium which overlies the cornea. The body of the pterygium is the one which is on the conjunctiva. And the junction between the head and the body is known as the neck of the pterygium. This whitish tissue that we see here is actually the elastotic degeneration, which needs to be excised and addressed during our surgery. So let's look at the first step of the surgery here, which is the excision of the pterygium head. This can be done in different ways. So in the first video here, what I'm doing is I'm using conjunctival scissors and going along under the neck of the pterygium to free up the tissue. And then I'm excising it with the conjunctival scissors, including the degenerated pigmented area that we sometimes see along the neck of the pterygium. Then I'm using two sharp forceps to strip off the pterygium tissue from the corneal surface and using a number 15 blade to make sure that we don't have any residual tissue. The other way to do this, as I'm demonstrating in the next video, is first stripping off or avulsing the head of the pterygium from the corneal surface and followed by excision at the neck of the pterygium. Again, we are using a number 15 blade here to make sure that we have a clear cornea and no residual tissue. Once we have achieved this, the next step involves dissection of the subconjunctival tissue. So here what we are doing is that my assistant is grabbing the subconjunctival tissue with another forceps where I'm holding the conjunctiva, and we are using a combination of blunt and sharp dissection techniques. So I'm going in with my scissors closed and opening my scissors as I go inside to achieve a good dissection and avoid buttonholing of the conjunctiva. Once we have freed up this subconjunctival tissue, we are excising it. And then we can measure the defect that we have created and harvest a appropriately sized conjunctival autograft. Again, I'm using the technique of blunt dissection here, and our aim is to achieve as thin a graft as possible, taking care that we have a minimal amount of tenons in our graft. A subconjunctival lignocaine or BSS can also be used to first make the plane smooth. After that, I am instilling fibrin glue here. The fibrin and thrombin components are being used separately in two 1 ml syringes, and then the graft is being positioned in its place. It is very important to iron out the graft properly and to remove any excess overhanging tissue on the cornea. This step ensures a good cosmetic outcome to the patient. This is the end of the procedure. And another technique that we can use is to secure the graft with sutures. This video has been shared by Dr. Namrata Sharma. We can see here that this is a very large pterygium and a lot of the cornea has been involved. So after dissecting the tissue from the corneal surface, this degenerated tissue is being excised. And we still see that we have a large amount of residual tissue on the cornea. So a crescent blade is being used here, trying to make sure that we do not create multiple planes and we have a smooth dissection. This would ensure minimal amount of astigmatism. So we have to be very careful in these cases for the underlying corneal thinning, and might be worthwhile to keep a lamellar graft just in case the cornea is really thinned out. After harvesting the conjunctival autograft here, it is being secured in place with the help of 8O vicryl interrupted sutures. So this is the other method of securing the graft. We can use interrupted sutures to ensure that the graft remains in place. And since in this patient there's a large epithelial defect, a bandage contact lens is being applied. So where do we place the sutures? If we have, this is the graft in this case where my mouse is, this is the conjunctival autograft here. What I typically do is that I place these 8O vicryl sutures at all the 4 edges and another one over here to make sure that the conjunctival autograft is well apposed. If needed and we feel that the apposition is not good at the limbus, 2 additional 10O linol sutures can also be placed at the limbus. What are the advantages of using fibrin glue over sutures? Shorter surgical time is one of the greatest advantages. In the Cochrane review, it has been found that on an average, it takes 17 minutes lesser. Patients are more comfortable. They complain of lesser watering and foreign body sensation post-operatively. There is some evidence to suggest that there might be lesser chances of recurrence. And of course, there are no suture-related complications. Now, the surgical time especially becomes important in patients like these. We can see that this is a patient with pterygium and a very hard mature cataract, and this patient has a double-headed pterygium. So in these patients, we do not want to have a very great amount of surgical time. So just to quickly run over this video of a double-headed pterygium. So again, what I'm doing here is that I am excising this tissue at the neck and making sure that the head is freed up at both the nasal as well as the temporal side. And once we have achieved this, this head can be stripped off from the corneal surface, which is being done on nasal and temporal side. And then we are using the sharp as well as the blunt edge of the number 15 blade, making sure that we have a smooth dissection. And then we can go ahead and remove all the degenerated subconjunctival tissue, taking care that we do not cause any buttonholing over here, and we can achieve a smooth dissection. This is subsequently being excised, and similar step is being rotated or is being performed at the other side as well. It is very important to measure and mark in these double-headed pterygia because we need a graft which is large enough to cover both the defects. So this step becomes important in these cases. After getting the conjunctival autograft, we are dividing it into 2 and then securing it in place using the fibrin glue. So if we had to use sutures here, it would definitely take us much longer to finish the surgery. And with the glue, this becomes very, very easy. It can be ironed out very nicely, and we can see that the apposition is also good. So at both the sides, we have managed to harvest enough amount of autograft to secure it in place. And this is the end of the surgery. Now, what are the disadvantages of using fibrin glue over sutures? It is much more expensive, and this is very relevant in the Indian scenario. Not all patients can afford fibrin glue. There is some low level of evidence to suggest that there might be higher chances of graft dehiscence when we anchor the graft with fibrin glue. But this graft dehiscence depends on a lot of factors, including preparation, manipulation of the graft, the surgical experience, as well as eye rubbing by the patient post-operatively. So what can we do to minimize these complications? There are a few tips. First is to achieve as thin an autograft as possible. Secondly, to dry the scleral bed before we apply the glue so that it adheres well. Application of the thrombin and fibrinogen separately so that we can achieve a nice thin layer of the glue, and it also gives us the time to make sure that our graft is secured in place. Trimming off the excess glue is very important. We can see here that I'm using scissors to trim off this excess glue, because if we don't trim and we pull or we remove the wire speculum without trimming the glue, we can actually pull the graft along with it. We must educate our patients and ask them to avoid eye rubbing post-operatively. Another technique of securing the graft is use of the patient's own blood. Fresh capillary blood is made to use, and the fibrin in the blood adheres the graft. But this technique has been associated with some complications like subconjunctival hemorrhage, graft edema, graft retraction, and most importantly, graft loss. Therefore, this is not my preferred choice when it comes to pterygium surgery. Post-operatively, the patients are prescribed steroid, antibiotic, as well as lubricant eye drops. So the take-home message here is that conjunctival autograft is the current standard of care for most of our cases. A thin, meticulous preparation of the graft helps us in achieving a good cosmetic outcome. Anchoring the graft with glue gives us again a good cosmetic outcome, reduces the surgical time, and is much more comfortable for our patients. We must remember to trim the excess glue at the end of the surgery to avoid graft dehiscence. Thank you for your kind attention. And before I end my presentation, I would like to thank all my mentors who have taught me this beautiful surgery. Thank you.